Good afternoon, everyone. Welcome to the Montreal Heart Institute. We're still waiting on our slides. I am Dr. Nosser, and with me here is my dear colleague.
My name is Philippe Lallier.
And my name is Sebastián Marat. I'm a fellow from Buenos Aires, Argentina.
And we're privileged to be working with our great team of personnel, Audrey, Véronique, Valérie, and Naili. Today, we'll be taking you through a step-by-step approach to CTO PCI for the non-CTO operator. So the objective of the case today and the presentation are understanding the fundamental aspects of CTO, PCI and its setup, analyzing CTO angiography and the process of lesion decortication, reviewing the various antegrade techniques and wires used in CTO PCI, and finally exploring the basics of retrograde approaches in CTO PCI. So Sebastian will present the clinical case.
Present the case today of a 77 male patient with risk factors known of hypertension and dyslipidemia, presenting to our center with angina, dyspnea, and a low ejection fraction, transthoracic echo that showed a left ventricular ejection fraction of 40% with a mitral regurgitation, severe mitral regurgitation, inferior wall hypokinesis, and a MIDI that showed severe ischemia on inferior and inferior lateral territory. The laboratory showed normal blood cell count, electrolytes, and renal function. Initially, we aborted with an angiogram performed on March of this current year that showed a proximal circumflex disease that was treated by that time, and also a mid-segment of the right coronary artery with chronic total occlusion that was referred for a second stage treatment. The patient remained symptomatic despite the vascularization of the circumflex artery and the optimal medical treatment.
So if we look at the criteria for appropriateness for revascularization in this case, we're dealing with a symptomatic patient that has ischemia in the related territory that is already on optimal medical management. And if we go through the table, then revascularization becomes uncertain, but depends on how you take the symptoms and how you take into effect the low ejection fraction, that's 40%. So it's either uncertain or it's adequate to perform the revascularization. And since the patient remains symptomatic with shortness of breath and occasional angina, we decided to go ahead with the revascularization of the CTO. Next slide. So we'll discuss the basics of dual injection angiography. When doing CTO PCI, it's very important to have an initial setup of a dual injection angiography at low magnification, permitting you to see both coronary arteries in the same frame. And when you start, you inject the donor vessel first. That way it fills the collaterals and goes to the target vessel. Then you wait 1 to 2 seconds, then you inject the CTO vessel. Very important not to do panning, because panning deviates the eye from the target collaterals and properly observing the proximal cap and the distal cap. And then you perform cine until the dye clears. So there are 4 key questions that you want to answer when you perform the dual injections. First of all, you look at the proximal cap. Now, is the proximal cap ambiguous or is clear and tapered? Then you look at the lesion length, because the lesion length will determine a lot your strategy, either being antegrade or retrograde, and which type of antegrade strategy that you will choose. And then you observe the distal landing zone, because if you have a good distal landing zone, it will change how the procedure evolves. And the collaterals, very important to look at collaterals. Are there bridging collaterals? Is there septal collaterals or epicardials? And to what degree are the collaterals developed, the tortuosity? All these are questions that you need to answer when you do your dual injection. And then you go through the hybrid algorithm. So we'll review currently the angiogram, and I'll let Philippe take over here.
Sure. So the angiogram is actually performing exactly as Dr. Nosser mentioned. We have the injection first in the left system, which is the donor vessel, and then after 1 or 2 seconds, injecting the right. Hopefully, we can have this angiogram up on the screen. We can actually see, again, the left system injected first. Then, of course, after 1 or 2 seconds, injecting the right, we see both vessels. we take orthogonal projections to see it in different views. So first and foremost, when we inject the left system, we confirm there are no severe lesions that would actually change the overall strategy for this patient. We see no restenosis of the circumflex PCI that was performed 3 months ago, and we see no progression of the disease in DLAD. So we're satisfied with this particular portion of the evaluation. And of course, when we look at the right coronary artery, we can actually see there are bridging collaterals that are somewhat of an issue because, of course, the wire will have a tendency to go through them. Second is that we can see nice collaterals coming from the septal perforators of the LAD going to the PDA, filling the right coronary artery retrograde. And we can also see part of the landing zone being vascularized by bridging collaterals. We see a good landing. Okay, so as far as the angiogram is concerned, we inject the left system first. We see the collaterals going to the distal part of the RCA. We inject the RCA a few seconds later. You can actually see the occlusion, which is about 15 millimeters in length. We see significant bridging collaterals, which make it a little bit more difficult to pass the wire through. So we need to recognize this first. The tip, the entry point is blunt versus ambiguous. But still possibly more blunt than ambiguous. There is a branch right at the occlusion site. And of course, when we see the landing zone appears to be fairly good size, so we consider it a good landing zone. So when we use the JCTO classification, we scored it as a JCTO score of 1 due to the blunt tip. There is minimal calcification, angulation is limited, and overall performance of this PCI for us would make us go through an antegrade wire techniques. Okay, we have maybe the next slide, please. You can show maybe a slide to go through the actual algorithm. So we see orthogonal projections, which is of course key to evaluate angiographic disease. No question about it. It's important. So we take at least 3 projections to see, again, whether there are a restenosis or progression of the LAD before we actually go through the PCI. Very important to reassess the situation carefully.
Can we have our slides, please?
Can you guys show the slides, please? Yes. Okay. So maybe the next one. Yes, so the initial stepwise plan, we'll pass the microphone to Dr. Noser. He will actually mention the actual strategy.
So since we're dealing with a JCTO score of 1, the initial step plan logically has to be antegrade wire escalation. The only difficulty you anticipate at this point is that there's kind of a blunt stump and there's a bridging collateral coming right off and there's a small branch. But probably won't be that much of an issue. We'll see that. This is our choice of wires in a ascending manner. So we're going to start with the Fielder XTA to see if there's a microchannel that connects that's invisible. Then if it doesn't progress, we'll still stay in the polymer jacketed wire, the Gladius, and we'll see how that one goes. If we manage to get subintimal at this point or intraplaque, then maybe perhaps form a knuckle and try to get parallel to the lumen and try at this point a sting brace re-entry. If the Gladius doesn't go as expected, then we'll give a go of a Gaia second next. Since the Gaia is very directive wire and we have a short CTO, it's worth giving it a try if it avoids antegrade dissection and re-entry. Now, if we cannot get through with using antegrade wire escalation, we'll move to ADR. So ADR, as I mentioned, a knuckle followed by a stingray. If that doesn't function, then we have a retrograde option, which was the second septal. If we can show the views, we'll perform septal surfing. Next view, or come back one. Yeah, this one. So we see through the LAD injection that there's good septal connections and we can actually trace them through the septum to the PDA. So that would be our third option. We'll use the probably cyan wire at this point or cyan black. And depending on how we approach the distal cap, either retrograde wire escalation or we'll have to do reverse cart. and if our bailout strategy would be star and investment procedure for next step. So without further ado, we'll start working. And I just want to show you how we shape the wire. If you can zoom in on my hand. So I already have the tip done, which is a millimeter at the tip and a bend. That's the Fielder XT. And we'll go ahead. Can I have the torquer, please? So we already have the Corsair Pro XS. Can I see the next slide? Just explain the setup. We have a right radial XB35, which is the donor vessel with a wire in the LAD. And we have a AL 0.75 through the right femoral, 7 French. We have a Corsair Pro XS 150 antigradely, and retrograde, we don't have a microcatheter yet, but it will be the same one. So we'll see what the XT does, if you can find the micro channel. So we can already see the wire buckling, which indicates that it's stopping at the lesion. Our pressure on the right side is not very good. So we'll try to avoid injecting antigradely, which is always supposed to be the case. So we'll do retrograde tests.
And we purposefully have 2 setups to distinguish both catheters. So if we're going to do injections from the left system, it's going to be through the automatic injector. And if we're going to do manual injections, they will be through the RCA catheter.
So if we look, the XT looks like it took a microchannel and it's progressing. I think this is subintimal at this point. Test. So I think the XT is going subintimal here. Let's take a cine, see where the tip of the wire is. So I think I'm intraplaque to start, and then it goes subintimal. Oh yeah, it's buckling right on top. So here's a good time to do a orthogonal view to see where I am compared to the lumen. So let's go on RAO, and we'll do another cine. And so since the wire, the XT, it's a polymer jacketed wire, I'm not worried. I'm an extra vascular. I know I'm in the plaque. Let's do a cine here. So here, when you do an orthogonal view, you want to see where the wire is compared to the lumen. So I'm just right on top, and both are dancing in the same plane. So very important before advancing gear is to check where you are compared to the lumen in 2 orthogonal views, because a wire perf is forgiving, a gear perf is not forgiving. So let's go back to LAO view. And I'm going to advance my microcatheter, and I think at this point I'm going to switch to the Gladius.
So Mohammed, tell us how you know you're subintimal as opposed to close to the true lumen.
So I'm looking at how the wire is moving distally. And normally, if I'm in the true lumen, it should slide at this point, which is not happening. So we're going to take the Gladius Mungo. So I'm advancing the microcatheter. Now it's mid-plaque. We'll check it retrogradely.
Oui.
So I'm going to switch to the Gladius.
Vérifiez sa cuisse, s'il te plaît.
So Gladius is a polymer jacketed wire. It's one of the most recent additions to the CTO arsenal. It has a 3.5 gram tip. It's a dual core, and it has a very specific characteristic that the tip is very foldable. So it's a very favorable wire for forming a knuckle. You think about it as a Pilot 200 upgrade. Actually, I do most of my CTOs with the Gladius and with a success rate of about 70%, I would say. And since it's polymer jacketed also, it's very rarely perforates, stays in the vessel architecture. I think we're having some resistance at the lesion because my guiding was protruding outwards. So let's see what the gladius does.
So your tip shape of this wire in order to progress, was this pretty much the same as previously?
Same. But with the knowledge that it will knuckle a much more controlled fashion.
And your objective now is to re-entry or knuckle?
I'm trying to re-enter. I'm going to try to find another microchannel that re-enters. It's a very good wire to direct, and I think I have a tip is free. So let's do a cine here, see where I am. And honestly, since I've had this wire, the rate of retrograde. So I think it's taking a branch. We have less flow antigrade now. I think this is a branch. Can you check, Philippe, retrograde? I'm trying to redirect to go into the RCA because into this. Okay, that looks good. Can you please test? Okay, so I'm torquing the wire manually and I'm trying to follow the die, and here we go.
Okay, so very carefully, very controlled fashion.
And once I figured I was in the lumen, I saw the die in the distal bed, and then I just maneuvered the wire, make sure the tip is moving, that I'm not in a subintimal space, not to extend the hematoma, not to create any dissections. And I think seeing the wire like this, it's pretty much confirmatory. We'll just do one cine to make sure that the wire is in the correct position. And at this point, we'll advance the microcatheter and switch for a workhorse. And then we're ready for imaging. Okay, let's do a cine. Voila.
So once again, when the wire went into a branch, it gave the information that this was actually in the true lumen going into a branch, most likely. So very favorable scenery when you see that. When you go ahead and maneuver the wire downstream, all of this part of the procedure was not over enthusiastic. Very carefully, very careful manner, evaluate, assess, look at the wire tip, and eventually maneuver into true lumen. Because if you happen to be a bit too enthusiastic and you go too fast, you may actually be in the false lumen and create an issue for you. So go slowly and go progressively and in a very controlled manner.
So take a look at my hands. I want to show you how to manipulate the microcatheters in this setting. It's very important to have one hand transmitting the torque, one hand controlling the torque. And then you do at least 10 turns and 10 turns. Avoid over-torquing on one side, because if you over-torque on one side, microcatheter can break and you might lose the tip. So I'm having significant resistance at the lesion, but it's still advancing. It's very important not to push it. Just be a controlled manner and advance slowly and gently.
And you control the tip of the wire. You want to make sure
always keep an eye on that, definitely.
Stable.
So I'm still having a lot of resistance. Normally at this stage, it should fly through, but I don't. So let's take a supportive wire. I'm going to switch this for a workhorse. We have the, can I have the Scion ES wire, please? Scion ES, extra support. Since my microcatheter is in the distal bed, I will remove the gladius, not to cause any perforations distally.
One of the pearls is that while you do all these injections, you're not looking always and you're not seeing as well as you should possibly the guiding catheter in the left system. So putting in a wire in place to stabilize the wire, making it coaxial and keeping it coaxial throughout is kind of a safety measure. We strongly suggest you put in a workhorse wire in the LAD while you perform these tests and the CTO PCI of the RCA in order to keep it safe for the left system.
So Scion ES has a tip of a workhorse wire and the body of a supportive wire, which in this case I think is a good choice because I had a lot of resistance with the Corsair Pro XS coming down. I anticipate some resistance bringing down material. So our plan at this point is to perform imaging to have an idea if we crossed everything, intra-plaque, extra-plaque, also and to understand if we need to do any kind of plaque modification depending on the calcium findings. How do you remove the microcatheter at this stage? So there are multiple ways you can remove the microcatheter. You can either trap, you can hydroglide, or if you have a trap liner, you can use the trap liner. I think in this case, we will do a hydroglide. The way to do that is make sure the tip of the microcatheter is full of dye. You lock it, make sure you don't trap the wire. Then your colleague inflates at a high pressure.
And keeps it at the same pressure while it comes out.
And it comes out and nothing moves and you can look at the wire. I have a knuckle at the workhorse, so it's pretty safe. And now I think we'll perform some dilatation with a 2.0 by 15 or 20 balloon before the IVUS, which would be helpful to bring down the IVUS.
The information gathered while advancing the microcatheter is helpful because it's very unlikely we can actually bring the IVUS catheter without pre-dilatation here.
So let's see how the balloon goes. So far, so good. So this is a 2.5 12. So we'll be gentle. Let's go.
Okay, so we test first to see if it's in the right place or...
Yeah. I have resistance here. Okay, I think we can start here.
Yes, okay, so we go carefully. 6.
Can you save this, please? Perfect.
So because there is a proximal disease in the RCA, we still have not injected a single time in the RCA directly, the RCA guiding catheter. So it's 6.
Okay.
Yeah, and one more time.
One more time. All right. We'll prendre like this. So let's give some sedation at this point, please. 50 of fentanyl. I see the patient have some pain. So we're ready for IVUS. Ça va, monsieur? Okay. So it'd be very curious to see the amount of calcium, whether we had any intraplaque or it's all intraluminal. These are all very important findings. Also, for the durability of the work that we're doing, very important to be able to properly optimize and properly size your stents. Usually when you're dealing with CTOs, the distal bed is underfilled and there's negative remodeling. And when you open up the CTO, there's positive remodeling that happens. And if you do not properly size your stent, then you risk of having worse long-term outcomes with ISR.
So the IVUS catheter is currently the Refinity Philips Volcano system, the 45 megahertz system. The tip has been improved, so it should track better than the previous type of catheter, IVUS catheter. So we should eventually see it go through.
There you go, very smoothly. So we'll see where we. I think here we're at the level of that early bifurcation of the PL. I'm going to try to decannulate my guiding a bit so we can see the ostium. There you go. I think this is a good place to start.
Okay, we're going to start imaging, see if we have a
image
good
is
image.
good.
We're going to make sure we don't have a nerd as much as possible. Image quality appears to be super good to us. So we're going to start the pullback.
Let's go.
We're having a 1 millimeter per second pullback. We're pulling through seems to be the distal bed. We have limited disease at this segment, which is what we expected from angiography.
There's the bifurcation that we're talking about. So we'll try to stop before that.
A bit of nerd again, and the image quality has gone down, so we re-inject. Now we see plaque throughout the vessels, not very severe. Another branch. And we see a calcification, which is kind of spotty at this time. We are probably close to the lesion initially. So we see calcium, but it's a little bit superficial. We've never seen anything more than, it's always been less than 90 degrees. The occlusion is here, calcium now, but it's not, it doesn't seem to be extremely dense. Here's a bit more calcium we can reassess.
It doesn't seem to be that large of a vessel.
Of course, we could eventually give a little bit of nitro if the pressure will allow it. Now that we have reopened and gained some antegrade flow. Okay, so guiding catheter. So Mohammed, what's your assessment? I don't think we actually need to do plaque modification.
No, I don't think so either. I agree.
So I think right now the length of the calcification and the extent of calcification does not seem to be enough for us to justify plaque modification. So we think we're going to go through balloon.
So let's take a measurement of the distal bed beyond the bifurcation. Yeah, there. Stop there. And let's take a measurement at that point. Let's take some diameters.
And we are talking lumen.
Yep, that's okay. All the way down. Yep. How much is that? 3 millimeters.
Yeah, that's a bit more close. That's a bit closer to vessel size, no?
Yeah.
So if we take the measurement of the vessel size, we of course will need to downgrade a bit the size of the stent. You want to measure the lumen, please? C'est trop distal, non?
C'est proximal.
On va voir la distalité, non? Proximal dans le guiding, ça c'est le guiding, ouais, ça.
This is the beginning of the run. Distal landing zone. Can we stop somewhere in the middle to get a measurement? Yeah, there, for example, that's in the lesion.
So,
yeah, let's take a measurement here.
Now, of course, it's a diffuse disease, so we'll need to measure the vessel and downsize the stent.
Yeah. So I think if we do a 3.0,
yes, so
it should be okay.
Yes. So, tu mesurer dans l'autre horizontalement, s'il te plaît?
Can we get a 3.0 balloon, 3.020 non-compliant balloon?
Un petit peu plus loin que ça, s'il te plaît.
That's 3.4. I think if we stick to 3.0.
Ouais.
What do you think?
Yeah, so now we have a 3.7, let's say 3.75. We need to downsize by at least a half a millimeter. So we'll use a 3.0 balloon and stent. So we'll use a 3.0 balloon. And then we will give nitro and see how it looks afterwards. So when there is limited disease, we typically use lumen and try to get 100% of the lumen as far as sizing is concerned. If we have a diffusely diseased, then of course we look at vessel and downsize the eventual stent.
Okay.
Okay, we go.
Let's go gentle here.
We'll still go a bit carefully, but nothing seemed to be worrisome on the We are at the 10. Well expanded.
What do you think, Philip? Should we go all the way to the ostium?
I think so.
Yeah.
Because it seems to be the...
Or in the body of the CTO. Looks like we have some resistance there.
Yeah, it's only 8. We're going to increase a bit the pressure to 12. And we have 14.
Okay, I think it's expanded now. Yeah, looks okay.
Okay, we're going to give it another try, a bit more proximal.
But what would have been your choice had we not been able to expand this in terms of calcium modification?
Yeah, interesting. Of course, if this would have been the case, of course, we need to go back. I think the calcium was fairly superficial when we look at the IVUS. Of course, the IVUS will not be able to tell you whether it is deep as far as the thickness is concerned, but I think I would have used rotablator.
Okay. Yeah. And what about IVL? Since we already have a wire and we have some dissection planes.
It's possible, yeah. It can be used. Another good choice, I think. It's the superficial calcium that would have made me maybe use a
rotablator.
1.5 rotablator.
All right, that was good. So maybe we can do a little check retrograde, see if we still have flow into the RCA after the ACT is done. All right, let's see retrograde if we still have some flow.
Nitro maybe?
Yeah, we'll do a nitro anti. So there's almost no more flow through the retrograde. So that means we have good flow antigrade. So pressure is good at the ostium. Usually I don't like to inject since we did IVUS, but I think we can permit ourselves to do a small injection. I'm going to give one of nitro. Let's push it gently with dye. I think my catheter is pretty much in the half aorta, half ostium. Looks pretty good. Pressure is fine.
The risk, of course, while if you try to inject antigrade, is to promote and push a hematoma in the arterial wall. This would be, of course, a significant issue. But at this point, I think the vessel is actually good enough for us to assess and try to start to do stenting.
What do you think, Philip? Should we land it before that plaque at the bifurcation? Because there's a plaque at the bifurcation versus stopping a bit higher up.
I think we need another projection to actually see it the best we can.
Let's take an epicranial.
Yeah.
Because again, like mentioned before, there's negative remodeling in the vessel, and
I want to do a little bit of a test shot.
Some plaques tend to improve.
We don't see it very well. Huh?
No.
Okay, let's
go. Do an epicranial, maybe.
Let's go. You can actually see this a bit better.
It looks significant to me here.
Yes.
I think we need to cover it, and we'll manage that branch afterwards, or you want to put a wire?
I think we put a wire.
Let's get a run through, please. And let's start looking for a 3048 synergy. And if we don't have that, then we'll take a 3038. So for sure, the workhorse needs to navigate the proximal plaque. It's well open, the vessel. Should be okay, but we'll see. If ever there's issues, we can always use a dual lumen catheter. But it's very important to use a workhorse wire here and keep it moving.
You cannot force it down. It's not going to be a
workhorse wires, I've already had, if you knuckle them in such anatomy, you can still get into subintimal space and it can cause issues. There you go, that's smooth. That looks like the branch. I want to check here. Let's see if it's the correct branch. No, I need to come back. No, on prend le 38. Test. Okay, that looks like the correct branch.
Yeah.
Yeah, that's the correct branch. So it's an early takeoff PL. We still want to preserve it because you want to preserve most of your branches if you want to have good results on your CTO. What do you think if we take a short stent so we don't jail a long segment?
The so part you mean?
Yeah, and then we do overlap above because I don't like jailing long segments in case the wire, we have issues. So let's just take a shorter stent. Let's take a 3018 stent, please, just to cover that distal plaque, and then we jail a short segment. Yeah, then afterwards, we'll remove the wire, so we don't have to manage.
3020, yeah. Promise Elite, please. 3020, Promise Elite, s'il vous plaît.
So I think we went through all the steps of CTO that we would have done hadn't this worked, but we were lucky enough that the antigrade wire escalation worked. I think it's a very good lesson that no matter what collaterals you have and how much you think it's difficult, you should always go at it antigrade.
Yeah.
Because with the wire technology that we have right now,
and as you go through and as you progress through your experience, you will eventually understand what every single wire can actually give you as far as performance. And it's very important you use them in different scenarios, different clinical situations, even during your standard regular complex PCIs, so that you really eventually fully understand what each wire can actually give you and when you should use each one.
So there are some questions. I don't know if you want to, there's some questions on the screen.
So which stents are recommended for CTOs in recent guidelines? I believe this refers to stent type versus, of course, we always use unlimited use of, we always use drug-eluting stents. Which one particularly is useful? We're kind of fairly easy. Any kind of a standard usual stent will do for us. Mohammed, you have any comments with that?
I think you should not use BVS, you should not use BMS. That's clear.
3.0, so we'll go softly.
Probably stronger radial strength. I think we're good here.
Yeah, we'll go softly because I'm not sure of the size of the PL. We haven't gone yet with the.
All right.
Okay, so 6.
That was good.
Let's pull back maybe. And
there's another question that says, what are the complications and their solutions if a microcatheter tip breaks within the lumen?
So I've had this a few times. Microcatheter breaks. You can go on, let's expand the stent.
Yeah.
So it depends where it breaks. If you're intraluminal versus if you are subintimal. If you're subintimal, you can re-enter somewhere else and jail that tip, right? If you, and this I've actually used and has resolved issues for me. If you are,
you can leave the broken tip inside the false lumen, inside the arterial wall with no particular issue, right?
Yep, definitely. And you can just jail it, leave it there if you manage to gain access off. If you break a tip and you're on the wire, then you can try to cross beside it, inflate a balloon and pull back the gel tip. There has actually been a report by Azzolini that he's managed to get a rotowire through the broken tip and pulverized that tip with a rotablader. So that's been described also. So it depends where you break, but of course here the key is to try not to break anything and recognize when things are not crossing and things are not moving properly that you stop before. So we'll take a small test, see if the bifurcation is okay. And if the branch is still there, it's a bit pinched. Let's go to AP cranial.
to see the tip.
To see the brand, yeah,
Because we didn't see it so well. We can actually take.
Oh, it's pinched. You want to do it? Let's do a. Let's get another run through. So the branch is jailed. The distality looks pretty good. So we're going to try to recross in that branch and inflate a small balloon. We'll just do a provisional at this point.
On prend un autre run through, s'il vous plaît.
We have the other run through. But there's a whole chapter of complications in the Manos Berlacus book about lost tips and broken parts. And there's algorithms for all this. So if you're starting a CTO practice, you should probably get familiar with these books because they combine the information from very experienced operators and high volume operators. You don't need to start from scratch and make your own algorithm of how to manage such complications because many of that already exists. And people have done many of those. So I'm trying to keep my tip flexible to get until the distal.
Normally go through the stent now. You want to make sure you're in the right place.
So the branch was pretty tight. Let's change projections because
which one did you want?
Yeah, let's try that one. Can we have the reference, please, of this view? So the angle here was pretty acute of this side branch. I don't know to what extent it's gonna worth spending a lot of time on, but we'll just give it a try. Maybe with some luck, we'll get through. Looks like luck is, there's too much overlap. Yeah. Let's go back to REO 30.
REO or LEO?
LEO. Yeah, so I think luck is on our side. All right, let's take a 1.5 balloon, please. 1.515. We'll just open the side branch and then we'll go at 1.5 and a 2.5.
Want to pull the other wire?
I'll leave it for now. It will be when you cross a side branch and you have a jailed wire, it's very useful to keep it in place until your balloon is through. That way it gives you some support to pull on the balloon. So I had issues passing a run through. In that case, I don't think trying a 2 is a good idea. We'll start with a 1.515 balloon. Yeah.
And of course, the plan for now is to optimize the bifurcation. Once this is done, of course, stent until we reach our proximal landing zone, which is in this case the ostium of the RCA.
So can we get back our slides because I see it's getting to 3 o'clock, and maybe we'd just like to go over a few things before we go offline. The rest of this is just basic, usual stenting, and we're going to deal with the bifurcation provisionally. We're going to implant another stent proximal, and then we'll do IVUS to finish off. So do we know if it's going to cut soon? If so, we'll just go to our slides and leave you guys with some conclusions.
So, of course, if you guys are not lucky enough to be scrubbed with Dr. Nozer, who actually succeeded at passing this wire, made this look so easy that it's once you want to give it a try immediately, but you need to be ready to do any other type of technique if you have to. So success rate is actually dependent on being able to go to the next step and eventually plan for whatever you need ahead of time. That's very important. Second is that you need to assess the angiogram carefully from the beginning and plan ahead for plan A, plan B, plan C. Of course, this is absolutely key, and you have to be able to look at the angiogram. Dual injection is, of course, something that you cannot go around. You need to do this in order to fully understand the anatomy and the relationship between collaterals and the actual occlusion. And maybe if we can have the final slide, the conclusion slide on the screen would be helpful. But globally speaking, you need to be able to troubleshoot. Some of the questions came with regards to complications. It's of course important to look at the strategies to do troubleshooting when complications occur. But of course, you should read things beforehand in order not to be caught by surprise. Otherwise, be ready to do any kind of strategy that you need to do. And of course, keep it simple as much as possible is something that should really be at the forefront of your thinking when looking at the original strategy. Can we look at the final slide, maybe the conclusion slide? Yes, we go. On 12.
That's perfect. We can give Nitro do a shot here, and if it's okay, then we just remove the wire and implant proximally. We'll prepare the 3038.
Yeah. Nitro?
Yeah.
Nitro 1 cc.
All right. Probably a bit pinched, but I wouldn't do dual stent strategy here.
I think this is actually pretty good, Mohamed.
Yeah. So let's take the 3038. I'll remove this wire. Very important not to jail a wire on two stents. If you don't want to have any lost tips.
And one more issue is that if you look at the distal bed of this vessel, it's currently being caught by surprise by antegrade flow. It actually looked a bit better